Hello, and welcome to POMA Does, a podcast produced by the Pennsylvania Osteopathic Medical Association. We provide a voice for osteopathic medicine and share insights on issues important to osteopathic physicians, residents, and students, as well as those who embrace the osteopathic philosophy. POMA's mission is to promote the distinctive philosophy and practice of osteopathic medicine in Pennsylvania for our members and their patients. Thanks for tuning in.
Hello there, and welcome to POMA Does, our podcast series presented by the Pennsylvania Osteopathic Medical Association. We are so excited. This is our first podcast that we're able to offer for CME credits. CME credits are available for this episode, and to claim those credits, visit the webpage noted in this episode's description or visit POMA Does podcast page on the POMA website for instructions. I'm Lisa Witherite-Rigg, and I'm the president of the Pennsylvania Osteopathic Medical Association. I'm an osteopathic family physician, but I'm here this evening not as an osteopathic family physician. I'm here as a family member, a friend, a relative of folks that have been affected by COVID-19 pandemic, as we all have been, but have been a bit hesitant in getting those vaccines. Now, this podcast episode is supported by the Facts on Vax Coalition. The Facts on Vax Coalition is a collaboration of the Pennsylvania Osteopathic Medical Association, along with the Florida, Michigan, Ohio, and Oklahoma State Osteopathic Associations, along with the AOA. We collaborate because together we can do more. The coalition works to address COVID vaccine hesitancy in our communities and is supported by Pfizer. This episode was developed entirely by the Pennsylvania Osteopathic Medical Association. None of the panelists this evening or planners of this episode have any conflicts of interest to disclose. And with that, I would like to introduce our panelists. First, we have Dr. Bernard Audukaitis, who is a pediatrician. Can you tell us a little bit about yourself?
I'm a general pediatrician. I'm in a rural area. I practice with Integrated Medical Group, which is a practice without walls. We have about 8 pediatricians in the group. I practice with a nurse practitioner in one office and with a colleague and a PA in a second office. And I've been doing this for about 35 or 36 years. So I've had a lot of fun. I still want to practice another 10 or 20 years.
Bernie, thank you for joining us tonight. Next is Dr. Scott Glassman.
Hi, I'm a psychologist at the Philadelphia College of Osteopathic Medicine, where I work with family physicians, family medicine physicians. For the past 14 years, I have been interested in motivation, healthy lifestyle change, and patient-centered communication. So I do a fair amount of training of medical students and psychology students in how to have conversations that really increase individuals' readiness to make good decisions in their lives, whether it's around diet, exercise, medication adherence, chronic disease management. So I feel like I've been thinking about this idea of hesitancy for quite some time as a psychologist, and so I'm really pleased that we're having this conversation around vaccine hesitancy, because I think it's really important.
Scott, thank you for joining us. Folks that are listening, you might recognize Dr. Glassman's name. He did a fabulous presentation at our spring conference on vaccine hesitancy and motivational interviewing. So again, Scott, thank you. And we have Dr. Alejandro Delgado. Dr. Delgado?
Hi, thank you very much for having me on. I'm Alejandro. I am an adult infectious disease doctor. I practice in Philadelphia and in Montgomery County. I am involved in teaching of residents and fellows, and I also wear a second hat as one of the hospital ethicists for the medical center in Philadelphia. I've been pretty involved in all things COVID for the last 2.5 years, both from the medical side and also from the ethics side, both in helping decision-making in patients in the hospital and in vaccine allocation, both for the state of Pennsylvania and for our hospital system. Thank you again for having me.
Alejandro, thank you so much for joining us. So when I was younger, I really never liked history at all. And then as I matured, I learned that history oftentimes will repeat itself, or we can learn so much from looking back. So as I was researching pandemics and things that have affected the United States, I came across an article on history.com, and it listed the 10 deadliest events in US history. And again, these are not age-adjusted numbers. These are just raw numbers of people that have died as a result of an event. And number one is the COVID-19, with over 1 million deaths attributed to COVID. Number two was the Civil War, and that's 750,000, and the Civil War lasted about 4 years. Number three is the AIDS epidemic, and the death toll there was 700,000. That was about a 30-year span. Number four was the 1918 flu pandemic, about 2 years, 675,000 people. And number five was World War II with 405,400. That lasted about 6 years. So we have 3 viruses and 2 wars. And, 2.5 years into this pandemic, and we're still having concerns. What we do have that they didn't have in 1918 is vaccinations. So that's what we're here to talk about tonight. What's available, how to help our patients understand what's available, and how to help them make decisions that are right for them. And I want to start with Alejandro. Can you tell me, first of all, who absolutely shouldn't get vaccinated?
So the amount of people that shouldn't get vaccinated is infinitesimally small. And essentially, it only compromises people who have had a severe allergic reaction to the vaccine or one of the vaccine components. Short of that, there's really no major contraindication to this vaccine. And I can't quote raw numbers off the top of my head, but really the vast majority of people would qualify for the vaccine. Of course, at least as of 8/18/2022, if you're younger than 6 months, then not yet, but everyone over the age of 6 months outside of that small group should be a candidate.
And as far as, long-term effects or side effects and things like that, Bernie, are you seeing any problems, especially with the children that have been vaccinated?
I have not. There have been some recent studies. There was an article in The Lancet on July 1st that looked at risk versus benefit, or potential benefits versus risk. And there was clearly more benefit than risk, but there was still a risk for some post-inflammatory syndromes like multi-system inflammatory syndrome of children and carditis from the vaccine, but they were proportionally very small. I do think we need to find and study and look at the risk versus benefits for our pediatric population, since we've been relatively spared. But clearly from 5 years and up, the risks are very low and the benefits are high. There have been 1 million doses of at least one dose of the vaccine given to 6-month to 4-year-olds, and we haven't seen any signals for significant side effects as yet either. So while we're blessed in pediatrics, the risks of the vaccine are quite low and the benefits seem to be quite high.
Great, thanks, Bernie. So Scott, one of the hallmarks of osteopathic medicine and primary care and collaborating with our patients is meeting our patients where they are. How do we approach folks that are kind of on the fence, not quite sure whether they should get it either for themselves or their kids? How do we approach that?
Maybe a good place to begin answering that question is how we shouldn't approach conversations around vaccine uptake when our patients are on the fence or ambivalent. And one of those ways is being confrontational, pressuring, trying to use information as a persuasive tool. Because one of the things that we know from psychology is the idea that we respond with reactants when we feel pressured to do something that we're not quite ready to do. So a provider who's feels like they need to argue with all the facts on one side of it will actually elicit arguments from their patient on the opposite end of the spectrum. So as a remedy to that, what we've learned from the evidence-based practice of motivational interviewing, which has over 30 years of empirical support in helping people have conversations that lead to healthy decision-making, we know that beginning from a place of empathy, validation around a patient's concerns with regard to the vaccine, no matter how far afield they seem to us as doctors, providers, is really important in building a sense of trust, a sense of feeling accepted, and paradoxically, that leads somebody to be more willing to explore some of the positives of getting the vaccine for themselves or for their families. So I think it begins with the willingness to set aside our clinical agenda, our agenda for the 5 to 10 minutes perhaps that we're with the patient, and really listening with great care and great acceptance and great curiosity about where that hesitation stems from, because it could come from many different sources, and it could be faith, it could be worries about side effects, it could be maybe a family member had a bad reaction to a vaccine. So being respectful of that, I think, is a very good place to begin, and realizing that we have pathologized ambivalence just as a whole in the healthcare field, and really blaming the patient, kind of labeling the patient as a resistant patient when they don't decide to make the healthier choice. So if we can really see ambivalence as a normal part of the human experience when we think about making any change, part of us does want to do something and part of us doesn't want to do it, we can go a long way toward building that kind of understanding.
So thanks, Scott. One of the things that I do when I'm talking to people that have chosen to not yet be vaccinated against COVID-19 is, tell me what you know about the vaccine. And the first thing that almost always comes out is, it's going to change my DNA. And I'm going to throw this back to Dr. Alejandro. How do we respond when folks say, I'm not going to get that because it's going to change my DNA?
Yeah, I think Dr. Glassman's help would be very appreciated here. So I agree, because I can probably explain how, this is for example, with the mRNA vaccines, which would be the one where they would be concerned about, I can explain how, the mRNA gets degraded very quickly. There's nothing that gets integrated into the genetic material of the patient. You're just using the patient's cells, machinery to produce the spike protein, to which they will then generate an immune response to. But I agree with Scott that appealing to facts doesn't always necessarily bring out the result that you want. I think you start with the facts, but you have to also appeal to I don't want this to sound the wrong way, but emotion, and their sense of greater good and impact on their community. But how do I explain to, the best I can do is explain the facts. This is a molecule that gets degraded very quickly. It'll turn on the system for a little bit and then go quiet. You'll have an immune response and it'll go away.
So Bernie, what concerns have parents shared with you about having their children vaccinated?
They worry primarily about side effects and the lack of long-term studies. So we have, a couple of years now of good data using the VAERS system, the vaccine reaction system, the system that looks at vaccine side effects. And while there are some, the vaccine is really very, very safe and appears to be very effective at preventing severe disease. And that really is the endpoint. And that's what I try to emphasize with parents. But they worry about those long-term side effects. Is my child going to have a problem a year down the line, 2 years down the line, 10 years down the line? The other thing they worry about is the carditis that's been reported, especially in males 16 to 26, 28 years of age. That's a real side effect, but it's about 1 in 10,000 males and probably somewhere between 1 in 100,000, 150,000 women. So those are really low. And the risk of carditis, especially with things like the multi-system inflammatory syndrome, the MIS-C, is probably somewhere south of 1 in 100, but still, several orders of magnitude higher than the risk is from the vaccine.
So, Scott, when you identify with an individual something specific that is kind of preventing them from being vaccinated, like the fear of side effects, or the unknown, that the thought that it was rushed into to create this vaccine, if we can identify that single thing, what's the best approach for those folks that have just that one holdup?
I think it's helpful to begin with autonomy support. One of the basic human needs is our need to feel that we can make our own choices, own decisions without being forced to do so, or forced into something that we're not ready for, that we don't want. So a statement at the beginning of that conversation along the lines of, I respect whatever decision you make today about getting the vaccine. And at the same time, I'm curious what you have heard about the side effects. Can you tell me a little bit more about your fear? And that open-ended question that follows autonomy support really then can help you understand that fear a little bit better. And then the next step within that process may be a very gentle question, asking permission if it's okay for me to share with you what I know about what's been reported in the literature about side effects and how common they are. Again, you're entering in a very collaborative, partnering, respectful mode. Of course, that patient could say, no, I really don't want to hear that because I've read everything, or I know it already, and I'm ready to move on to another focus of our conversation. But usually, if you ask respectfully, the patient will say, sure, yeah, can you tell me what you know as a physician? Providing that information, and then we call it ask, offer, ask. So at the end of providing the information that you have, asking for their reaction, and maybe even supporting their autonomy again toward the end of that information exchange process. So when you hear that the side effects are very, very, very rare, how does that affect how ready you are today to get the vaccine, or how important it is for you today to get the vaccine? And I do understand that this is something that only you can decide, and it is completely your choice. So I really like that kind of bookended way of helping provide our expertise, but not wielding it like something that's going to be threatening to that patient.
But also, I like how you said restating what your understanding of their concerns is so important. And, the key here is collaboration. I think the key is collaborating with your patient to allow them to make the decision that is best for them. but collaboration in other areas is also important. And, one of the concerns that has been voiced to me is, well, they put this vaccine together too quickly. And I'm going to ask Dr. Alejandro about how the vaccine was made, where the technology came from. And even though it seemed like it came very quickly, this technology's actually been around for a while.
That is correct. So we'll start off by saying that this is by far the vaccine that's been developed the quickest in the history of vaccines, by no small measure. But these were also very extraordinary times. And you're right, although this is a novel technology in that it's the first time that a vaccine has successfully been developed using it, it's not a new technology per se. It has been floating around since at least the mid 80s, I believe. And it had been worked with multiple times, and not just in the field of vaccinology, but really in treatment of multiple diseases, cancer being a prime target. And I think that this is what we're going to be seeing moving forward a lot. Also, we've never seen a vaccine where there was such worldwide cooperation between pharma, governments, the World Health Organization. The amount of funding that came into this vaccine is unprecedented. And also, we tend to think about things in time, transpiring, but if you think about it as the amount of patients enrolled and the amount of disease present, that also helped accelerate the vaccine development. What was done with Operation Warp Speed was also pretty extraordinary, getting the vaccine out and distributing it, with all the bumps in the road that we had in the beginning, was pretty extraordinary. But this was every step that had to be taken to ensure safety, immunogenicity, efficacy was taken. There were no corners cut in making this vaccine. It's just the amount of resources and the opportunity for cooperation was unprecedented.
Alejandro, there are other vaccines with this technology for other diseases, correct?
No, not right now. No, we are very, very hopeful that this will now be used for other conditions, and not just infectious diseases. Like I said, for autoimmune diseases, for cancer, an HIV vaccine, I think, is being developed with mRNA technology. So I think that this it's the new kid on the block, although it's been in development for a while. It's more like in its mid 30s. And this is probably the future. Now, there are other vaccines available which use more traditional vaccine platforms. In the United States, we have the J&J vaccine, which is an adenovirus vaccine, and we just had approval of the Novavax vaccine, which is a protein subunit vaccine with an adjuvant. So even for people who may have concerns about the mRNA technology, well, here you have another option, which was it's a more traditional type of vaccine, if you wish to go that route.
So, and I'll throw this out to both Bernie and Scott, and mostly Bernie and Alejandro. We're not doing that bad on the initial series of vaccines for adults, about 70% in the state of Pennsylvania. But then when we talk about adding on those boosters, we're not doing so well. And our kids, we're really not doing that well. Bernie, any thoughts on the why or what we need to do?
I don't know. I'm a disciple maybe of Dr. Paul Offit, and he's skeptical about boosting low-risk populations. The immunization advisory committees have also been somewhat skeptical of boosting low-risk populations. So I think we need a little more study as to who benefits from boosting and what the optimal time frame is for boosting. I, for one, have a little bit of trouble recommending routine boosting for most of my patients who don't have underlying conditions like obesity, like diabetes. it's a little more complex than just saying you ought to get boosted and that boosting is beneficial. We probably benefit from increased antibody levels for up to 4 months, but it may not give us long-term protection, and it may not give us a whole lot of additional protection, at least from severe disease. So I'd like to hear what Alejandro has to say.
I'd like to challenge that notion a little bit, because while I agree with most of what you said, with a vaccinated young person without any immune suppressing conditions or comorbidities, your baseline risk of ending up in the hospital is not that high. But it is evident, and I was trying to pull up the data from CDC that I had before, that especially, of course, this applies much more to older populations, but the difference in hospitalizations and severe disease in patients who get boosted is very, very significant compared to unboosted patients, 3rd dose, 4th dose. Now, I do think that there's a bit of diminishing returns, and with the pediatric population, I'm just going to zip my mouth because that's a different beast altogether. But I think that the notion of boosters with a virus that's evolved this quickly, where we had data from the original trial with the ancestral Wuhan strain that the vaccine had 95% efficacy in decreasing infection. Well, it turns out that the virus likes to mutate, so that's a little bit lower these days. It stands to reason that, similar to the influenza vaccine, which every year needs to be adapted, that would be the case for this vaccine. I also, and I wanted to say something earlier, and maybe get Scott to talk about this. When discussing risk, and I think this applies to boosters too, risk benefit. When somebody chooses not to get vaccinated or get boosted, you have to realize that you're not trading risk for no risk. You're trading one risk for another risk. So on the one hand, I have the risk of infection, and that's a very real risk. And we know what happens with infection. You can either have a mild course or you can have a not very mild course. You can end up in the hospital. There's some risk for mortality. And we know that long COVID is a very real concern. A not insignificant percent of patients will develop long COVID, ill-defined, but still getting some interesting information as of late, versus getting the vaccine. And we know that the vaccine can have side effects, but the likelihood of any side effect, as Bernard said, for example, myocarditis, is a lot higher with natural infection than it is with the vaccine. So you're not trading no risk for risk. You're trading a calculated risk for a much higher risk. And that's where I say, well, what's the downside of getting vaccinated as an individual? What's the downside of getting boosted? You can argue that from the macro perspective, from a government that's trying to organize a health system and spend its money judiciously and this and that, then you might start to see, well, what am I trying to achieve? Decreased infections, decreased hospitalizations, decreased mortality. But from the individual standpoint, I just really see a lot of upside and not a lot of downside.
So this question's for Scott. Scott, a lot of my folks in my circle that have chosen not to vaccinate, they say, we know so many people that got the vaccine and they got sick anyway, so I'm just going to take my chances. How can we engage that conversation and help them understand that I respect their opinion, but my opinion might be a little bit different?
Sure. I think first, I'd love to respond to Dr. Delgado's comment about the idea of risk benefit, because one of the strategies that we use in motivational interviewing conversations is to help patients explore the what ifs on the positive side. And the more we can elicit patient language that expresses desire or reasons for getting the vaccine, the more likely they are to decide to get the vaccine. So an open-ended question like, what could you see as the possible benefits if you did decide to vaccinate your child or get vaccinated yourself? How would that positively affect your life if you avoided severe consequences from COVID, or you had a greater protection from long COVID? And helping somebody actually articulate, well, that would allow me to work the way I want to. I wouldn't have to worry about this or that. And, I'd feel more comfortable about my child's health, my family's health, people who are immunocompromised within my family. That is, you're almost seeing the wheels turn in a consolidated increase in internal motivation, intrinsic motivation to make that decision. There's a saying that I learn what I believe about myself as I hear myself talk. And it's through conversations, it's through this envisioning process feels very safe, because you're not pressuring them to decide one way or the other, that you're helping somebody move closer toward that healthier decision.
Great.
I'm going to steal that question.
It's a good one.
So, and this is for all of you. Do you think access to vaccines for folks is a problem?
Yes.
Okay.
The amount of vaccine that needs to be purchased, if you're a small practitioner, there are limits for the under 4 now. They want us to acquire 200 doses, and I can't use 200 doses within the time frame that they expire. So I haven't been giving the vaccine in my office. Now, for my older population, it's available at the pharmacies. For my 5 years and up, it's available at the pharmacies. It's available at the local hospitals, and I've encouraged them to go there. It's also storage. I've got 2 refrigerators filled with private vaccine for children, and I've got a 1,200 square foot office. Where do I put all the vaccine? I'm working on that right now, and we'll probably be giving the COVID vaccine routinely in the very near future to everyone in my practice, in my office. But it really is, it's not simple in terms of the ability to acquire and store and document the vaccine. And in pediatrics, we're the best in the world at giving vaccines and doing this. And if I'm having difficulty, it's a problem.
Alejandro, do you see any access issues?
Well, I think very much so in the beginning of the vaccine distribution. Nowadays, at least in the adult population, it's as simple as booking your appointment on on CVS's website or going to a pharmacy. Now that assumes that you have access to a computer and an internet connection, and that's where it gets tricky for certain populations. So we still have patients who have a language barrier, for example, that might not have access to a computer, might not have access to internet. We know that in Hispanic and African American communities, there's less penetration of the vaccine, and sometimes it's an access issue, sometimes it's an issue still with vaccine hesitancy. But compared to what this was a year ago, it's very easy to get the vaccine. Right now, if you have a laptop or you have a pharmacy close to you, you should be able to get vaccinated.
So Scott, I'm going to throw this back to you. You have a patient, you're talking to them about vaccines. They're thinking, you know what? Yeah, this is probably the best thing to do for myself and my family. And then there's a delay in them having to get that vaccine. How is that going to affect them?
Yeah, so one of the things we know about motivation to change is that it can wane. If you're ready to make a decision with regard to diet, exercise, vaccine uptake at the end of an office visit, that's ideally the time that you'd want to schedule the appointment or actually get the vaccine if that's possible. We know that if time passes, it may or may not really affect somebody's intention. I mean, it could diffuse a little bit, but there's an opportunity the next time that person comes in, that family comes in, to reignite the conversation around the perceived benefits, hearing any concerns or kind of the pause or the hesitancy may have resurfaced for some other reason, that we follow the same process of listening empathically, validating fear, providing information in a collaborative style and an exchange-oriented style, supporting autonomy, and at the same time helping them envision again, how would getting the vaccine be consistent with what you care most about in your life? It's obvious we use in motivational interviewing a good deal of affirmations, which is an identification of patient strengths. So I can see that you care about your health quite a bit today, and you're back in the office, and I'm wondering how this decision around the vaccine is consistent with your desire just to do the best for your family and for yourself health-wise. So values, behavior, consistency is one of the primary motivating forces in our lives if we're aware of what our values are. And I think providers can go a long way toward eliciting, evoking in a very compassionate way what someone cares most about. And usually that leads to good places in terms of healthcare decisions.
Great. Alejandro, we've really never seen anything quite like COVID-19. What can we expect? Is it going to go away? Are we going to see more variants? What's your best, if you had a crystal ball, what do you think?
I've gotten it wrong so many times this pandemic that I dare not say.
Okay.
So, I've become very hesitant in trying to prognosticate anything. I'll echo, not necessarily about COVID, but thinking about the next pandemic, which is right around the corner.
Yeah.
Fortunately, monkeypox at least is not an airborne virus, so it's still a big threat, still something to take seriously. But the biggest threat is going to be from respiratory viruses, with climate change, with humans encroaching into sylvatic areas, with all these issues happening at the same time. The next pandemic's right around the corner, and this pandemic was really a dress rehearsal. Yeah. It's been incredible. It's been like you said, it's killed more Americans than all our wars combined, and in a sense we got lucky, and I don't say that lightly. But if we had a virus that was more akin to a avian influenza, which is what we feared could have happened with H1N1, then we would have found ourselves in a very different position. In a sense, we were fortunate that this virus has a relatively low mortality rate, and that we did this incredibly miraculous thing where we developed a vaccine within a year. Next time, we may not be as lucky. So we have to continue collaborating with other governments, with other health agencies. We have to sharpen our tools to get the population ready for other vaccination campaigns. As far as COVID goes, who knows? I dare not say. Variants will continue to happen. That I think we can say for sure. It's probably not going anywhere. We're going to be dealing with this for a while. How long? I don't know.
Bernie, what have we learned about patient care? We spent so much time doing that one-on-one with our patients, then all of a sudden we're talking about telemedicine and communicating with our patients and treating them over the phone or over a computer. A lack of healthcare workers. What have we learned?
I've learned that I don't like telemedicine as much as I thought I might. I can't get the patient's, I can't read the patient's vibe as easily. I can't read their body language as easily. I can't smell the environment. I can't listen as easily with telemedicine. There's certainly a real place for it, and it needs a lot of research as to where we should use it and how we should use it. I think it's brought doctors and patients closer together over the long run. Patients are better informed than they've ever been. There's a lot of misinformation. But I want to ask Scott a question about some of the information campaigns. I find some of the commercials that I see off-putting, where I listen to them and I say, well, why would I get that vaccine? The government really wants me to get it. Why should I get it? I don't trust the government.
Yeah, so you're talking about one of the, when vaccine hesitancy was studied and what are the components of vaccine hesitancy when that was explored. One area is circumspection, which relates to a fear of the side effects, and another area is related to confidence. That's confidence, trust in the government, feeling that this is potentially a hoax or made up. And I think we need to be careful to understand how just providing information, may actually have the opposite effect of what we hope that information to have, based on somebody's maybe low level of confidence in the healthcare system, in the government, and meet that as providers, even though that may really push our buttons to have a very judgmental reaction with non-judgment, as difficult as sometimes that is for us, to come toward that and welcome that and meet that with understanding. Then if there's a window of the pro-vaccine side of the story for that particular patient, it's more likely to come out.
Can we as physicians make better information, better commercials?
I'm sure. CDC did.
Yeah.
I don't think so.
Okay. I just wondered from an osteopathic standpoint whether it's possible to take what you do, Scott, and put it into more of a listening mode, and saying, we know you have concerns.
Yeah, tell us what your concerns are. Yeah, I mean, if the information,
yeah,
if the information campaign suggested, tell your doctor why you're concerned, why you're worried. That could open the door to the conversations, the type of conversations that I'm talking about, versus just the information, the data itself, which we know may not be effective delivered in that mode. One of the things I just want to mention is that studies that look at providers who are trained in motivational interviewing, they're much more likely to document less vaccine refusals, particularly in one study when it comes to children. They were significantly lower, those refusals, for providers who are practicing this patient-centered style of communication, grounded in empathy. And if you're in the presence of delay or refusal, a lot of providers say that, MI gives me some place to go. 2/3 of them said, I feel like I'm not casting about in the dark when I meet that refusal or that delay intention. So that's hopeful.
Yeah. And I think we could do, our coalition may be able to do more, and this may be a model for how to communicate with patients using media. That we're listening. We're here to listen rather than to tell you what to do.
Listen rather than lecture. Exactly. And
I'm still learning how to do that.
And Bernie, one of the things you brought in was the government influence. The one thing that Alejandro hit on, though, is one of the reasons that we were able to get this vaccine developed so quickly was because of collaboration, not just our government, but other countries and companies. And, the companies set aside, their need to make money or revenue, and everybody just kind of put what they knew together to make this happen, which is amazing. Something that normally takes 8 to 10 years. So, and Scott, I want to ask you this, and we touched on it a little bit. As far as our socialization, what have we learned? We've been isolated for a while, and then, we were starting to get out there a little bit, and then it was kind of pull back in. What does that do to us as individuals?
I think it's made us really appreciate the value of positive human connection, caring, kindness, and concern, maybe in a way that we hadn't felt it before, because when living in our silos and after quarantines, and even now, being remote, many of us still remote for a good percentage of our time, it accentuates the importance and the value of every interpersonal contact that we have. Every interaction takes on that much more meaning. And if we can devote the kind of care, study, and interest in what are the dynamics of that, even brief interactions, a 5-minute interaction can make a big difference. Motivational interviewing is typically about 10 to 15 minutes. It's pretty brief. Then I think we can go a long way toward rebuilding trust in each other, or a feeling of community that's been lost through the pandemic.
Thank you. I'm going to open it up to any last things you might want to add, Alejandro.
I guess I maybe some questions for Scott and some reflections. I'm thinking of some of the errors in communication that we made during the pandemic. You might have seen that Dr. Walensky, the head of the CDC, has called for kind of a restructuring of the agency, because recognizing that they didn't meet their own standards in management of this pandemic. And I think that although they did a lot of things very, very well, one of the issues that I think touches a lot upon what we're discussing here has been communication. We haven't done the best job in communicating with the public. I was, when you guys were talking, I was thinking about how do we get TikTok influencers on board? How do we get Nicki Minaj and celebrities on board? Also thinking about, why, how is it that, when, for example, when somebody gets, when we talk about how many physicians have taken the vaccine versus the general public, and most doctors have been vaccinated, and why is that fact not more impactful, Scott, to the general public? That's something I've always scratched my head about.
If it's good enough for my doctor, it's good enough for me, that kind of thing. Yeah.
Yeah. And, as a final thought, and a little bit on the personal side, I experienced this pandemic both as a physician and as a patient. About a year before the pandemic, I was diagnosed with ITP. So I spent the first almost 2 years of the pandemic on rituximab. So I was very scared that I was going to get infected with this virus. And I was very grateful to be amongst the first to be able to get vaccinated, even though my vaccine response was not the greatest. And eventually, this is going to catch all of us. It just caught me a few weeks ago. But fortunately, because I'm vaccinated, amongst other things, I did very, very well. And just to keep harping back on that, the virus has mutated. We have to be a little bit more honest about how good the vaccines are these days, a little more transparent, and that the virus has changed. The vaccine will probably change in the future. Here's the efficacy these days. Here's why we feel that boosters are important to bring up that efficacy. But one of the errors I think we made in communication was overpromise and underdeliver. And we got to be honest about that.
Yeah.
But we did deliver pretty well in terms of preventing serious disease. I have a question for you, Alejandro, though. In the near future, we may have vaccines that are more efficacious against the newer variants. Should we, as patients, be waiting for those vaccines before getting our 4th dose, or should we get our 4th dose now?
That's an excellent question, for which I don't have a perfect answer. I think it depends on your risk profile. I would say if you're a transplant patient or an older patient, maybe it's worth just getting your 4th dose now, ensuring that you have immunity, even as imperfect as it might be. You might get a symptomatic infection, but it's still going to do what's important. Where, again, to your point about over delivering, these vaccines really delivered well in stopping mortality and hospitalizations. The current scenario that we're looking at is that in September, we're thinking that they're going to be rolling out Omicron specific boosters. So there might be a benefit for some people who are lower risk just waiting to get that vaccine. There's some concern, although I don't know how justified. I wish we had somebody who had more knowledge in immunology about whether stacking the vaccines a little too close to each other would hamper the immune response to one booster versus the other. So not a cookie cutter answer for that one.
Thank you.
Scott, do you have any closing remarks?
Just that I hope that we continue to see the integration of psychology and behavioral health in primary care and other medical specialties, because if we can see health holistically as a mind-body wellness issue, then I think we go a long way toward addressing hesitancy with support in practices. So that's what I would like to see, as well as continuing to focus on our communication skills, our style, and looking at that just as much as we're looking at the facts and the data and new variants, because both sides of the equation are really, really important. And I'm so grateful that you've invited a psychologist to participate today in this discussion around vaccine hesitancy. So thank you very much.
Scott, thank you so much. Bernie, any closing remarks?
I just wanted to thank everyone who's here. I'm still learning. I've been practicing my approach to vaccine hesitancy my entire career. It has changed almost weekly. And what I've taught myself, and I try to teach my residents and students, is to just don't say something, shut up and listen.
So I want to close with saying, I think the thing that I learned the most throughout the last 2.5 years is we're really consciously thinking about how we live our lives and what we value. And I have firsthand experienced what I call the fallout of COVID. Things that we normally do, we haven't been able to do. Family members that die. We're not able to do our normal people things. Not being able to go about what our normal pleasures are. Grocery shopping for the first time for my 2-year-old granddaughter. She was terrified to get in the grocery cart because she never experienced that before. There's still a degree of shaming. And, if somebody does choose to wear a mask in a setting because they're immunocompromised, or because they might not be fully vaccinated, or for whatever reason, because they like how the mask looks, doesn't matter. We just need to be empathetic. We need to consider the body, the mind, and the spirit, because it's not just the illness that has affected us. It's everything about our human condition. So, gentlemen, thank you so much. This has been just such an exciting event for POMA to undertake. And hopefully, folks that listen to this podcast on COVID vaccine hesitancy will take home a tip or two to help their patients and their families.
Thank you.
Thank you, gentlemen.
Thank you for joining us for this edition of POMA Does. Be sure to subscribe to POMA Does wherever you listen to your podcasts, and tell your friends and colleagues to tune in. Learn more about osteopathic medicine and POMA on our webpage, www.poma.org, and join the conversation on social media. We're on Facebook, Instagram, LinkedIn, Twitter, and YouTube, or email us at poma@poma.org. We'd love to hear from you. Join us next time for another edition of POMA Does.